for joining us today, taking the time out of your busy schedules for the OTA LifeNet Health Industry session featuring Dr. Richard Yoon. My name is Rich Rice, and I'm the General Manager of Trauma CMF here at LifeNet Health, located in Virginia Beach, Virginia. We are excited to share with you some of the science behind two of the most innovative allografts we have ever launched. In today's session, Dr. Yoon discusses his experience with ViviGen Cellular Bone Matrix, leading to the title of his talk, Do We Even Need Iliac Crest Bone Anymore? Due to the large number of registrants, we have muted all participants. So if you have a question during Dr. Yoon's presentation, please feel free to type it into the chat box and send it in. We will try and address as many questions as we can. You can find the chat box if you hover over the thought bubble on the bottom of your screen. We will take a break at the halfway mark and address the questions received to that point. We will also address questions at the end of his talk. Also joining us from LifeNet Health are Dr. Elena Janulis, PhD from LifeNet Health, and Pyle Sahoni and Kelsey D. Crescenzo, two product managers for both ViviGen and PliaFX Prime. At this time, I'd like to turn it over to Dr. Yoon.
Thanks, Rich. I'm always excited to give a talk on ViviGen and your products. My name is Rich Yoon. I'm a Director of Orthopedic Research, and I'm an orthopedic traumatologist and adult reconstruction surgeon out in New Jersey. I hope everyone's doing well this afternoon. When it comes to traditional bone grafts, obviously as orthopedic traumatologists and orthopedic surgeons in general, we know that typically we're using bone graft for scenarios typical to bone voids and non-unions. This is just an example of a 27-year-old female with a massive defect after a battle with a high-energy rifle. And this is stage 1 of mascule, and this would be an ideal environment for somewhere where we need some kind of bone graft, either auto or allo, in order to get this young lady to heal. Another example of a 27-year-old female with a flail on with a proximal third non-union. Typically, we do something along the lines of either using a strut graft with or without iliac crest bone graft. And really, when it comes down to what options we really have, bone grafts in general are the second most transplanted tissue out of donations in general. And traditionally, what we have is cancellous autograft. We've all heard the saying "Crest is best" during our training because it has both the osteoconductive and osteoinductive properties, but also has the osteogenicity that we require to help kind of bone kickstart and get the healing process going. However, when it comes to Crest, there are issues. Oftentimes, donor site pain can be up to 2 weeks, sometimes even longer. In the literature, some donor site pain can be reported even up to 1 year. In my practice, sometimes even when the bone has healed at 6 weeks to 3 months, patients have come back and complained more about their hip than anything else. Some patients, especially in the elderly, as they're recovering, even if it's an upper extremity non-union, they may complain not only of pain, but some gait disturbance or limp secondary due to the pain. Obviously, those sites can be infected, especially those patients with a large pannus and a not so clean inguinal area. It can be an issue. Fracture, if you're trying to take too much of the crest, then your trapdoor is not as good, or the bone's more fragile. Fractures can certainly occur. And then we've all been there using those lemon baller curettes where we're trying to get as much crest out as possible. Sometimes, especially in the larger defects, you just kind of run out and you're left wanting for more. So really, as orthopedic traumatologists, you ask yourself, there is a better option. And your ideal bone graft is something that is, just like we said before, osteogenic, osteoconductive, and osteoinductive. And if there's a way we can avoid the crest to avoid all those situations we mentioned previously, that would really be kind of the dream, right? So when we're talking about an allogenic cellular graft, there are several options. And today we're here to talk about my experience with ViviGen. And really, typically in your ORs, just such like mine, my trauma rep is telling me that I've got to try this new product. And this is almost 3 and a half years ago now. And really, this is the face I usually give him when he talks about a new product that I don't really necessarily have enough data on, or anything that really, isn't in the mainstream in regards to evidence, especially at meetings such as this that we're at the OTA. And he just gently explained it. There are two types of it. One is kind of a non-formable and a formable version of it. where it has obviously cancellous bone chips for the osteoconductivity and the scaffold. It has the osteoinductive factors that you would like, but also the way that the ViviGen is prepared has osteogenicity and active bone cells that help kind of jumpstart the healing process. And really, this is supposed to be the an option or replacement to avoid that iliac crest bone graft. These are kind of the things we talked about, and especially the formable version that has the DBM fibers in it. It makes it much more moldable. And then later on, I can show you kind of an additional trick where I combine it with 100% DBM PliaFX Prime to make it even more formable and kind of mold to the area where you want it. And my first question, as he told me, because this ViviGen comes in the freezer, is it's going to take too long. Not that harvesting iliac crest bone graft takes long, but obviously if you've got your process down, you can get that done pretty quickly. But when it comes to ViviGen and rapid thawing, it's actually required that you do thaw it rapidly in less than 5 minutes. All you have to do is place this in some warm saline that comes out of the warmer that's next to every OR. And it really is actually as quick as it seems. And when I first started out doing this as well, after it thawed, I would sometimes mix it with bone marrow aspirate, which I got from Crest with a Jamshidi needle. What I would do is I would inject the aspirate within the bag to help it kind of fully soak in. I've evolved now to the point where I no longer even do the Jamshidi needle portion of it because I trust the product so much. But we'll go through the cases in which kind of led me to my belief in this product. So when it comes down to this matrix, it's got all three things that we want. And is it really possible? Is it really real? And after some begging and pleading, I said, fine, I'll try it. And literally, I picked probably the hardest cases that I could find first, expecting this thing to fail. There's a 46-year-old man that has post-pedestrian struck while crossing the street. This is obviously an open fracture dislocation in talus. My partner at the time took care of it, did a very nice job fixing the talus there. The patient himself had an odd affect, paranoid schizophrenic, and not surprisingly, after the surgery was done, he has lost a follow-up. He shows up in my office 6 years later saying he has pain. Obviously, he's developed tibiotalar arthritis there with flattening of the talus and complete obliteration of his tibiotalar joint. But because it was an open injury, and even though his incisions were well healed, I did labs and it was elevated for infection. So I did assume that this was infected until proven otherwise. We started out by removing the hardware, placement of an antibiotic spacer, saucerizing obviously the canal, placing some intramedullary beads as well. Got 6 weeks of IV antibiotics, and once the labs were negative, we were ready for replant. As we came back, we prepared both the tibiotalar and the subtalar joints. And prior to compression, this was where I placed the ViviGen. And a lot of times, sometimes you'll see that you have a little bit of leftover. So I packed the lateral aspect of the lateral column where I did the fibular osteotomy with the residual, because obviously not only is this a donated product, but throwing out bone graft is kind of like maybe how the sports surgeons feel about cartilage or taking the meniscus out. And we really don't want to waste anything that we kind of take, so that's where I left it. My typical post-op weight-bearing status for these patients is about now weight-bearing for 12 weeks. Obviously, due to his past psychiatric history, I wasn't surprised when he missed his first appointment and he was admitted for hypertensive psychosis. I saw him actually walking out of the hospital on his splint and actually begged him to come back to the office. He actually showed up for his 6-week follow-up with sutures still in, still walking on it. These were his x-rays at the time. I was waiting for broken hardware or some kind of deformity, but instead what I saw was, interestingly enough, callus formation on that lateral side where I'd left most of the extra ViviGen I had. Even here at 6 weeks out, you can see almost obliteration of the tibiotalar and subtalar joints in that fusion area. Still walking on it, even though I asked him not to. 3 months out, fully consolidated without any pain. And he actually did follow up almost 1 year out, saying that he had pain at the proximal screws, which were prominent and palpable. So these are final follow-up pictures over 1 year out after I took the screws out, and I haven't seen him back since. And interestingly enough, There was that consolidation on the lateral side, which I'd expected to resorb, but it actually connected the tibio-talar joints in that lateral column, which is pretty interesting for this product. Next patient I picked was actually not too far after I had staged the last patient. This is a 76-year-old male who was hanging Christmas lights. He fell off his ladder. He had a pilon fracture, which at an outside hospital was too comminuted, so they attempted a primary infusion. Problem was he had a history of metastatic prostate cancer, chemo, and steroids at the time. It was not healing well. Wound was not healing well, and he showed up in our ED with this wound, and these were his X-rays. Obviously, the fusion was not really working, and this was infected until proven otherwise. So, remove the hardware, cut out that large portion of the wound. Antibiotic nail was placed. Saucerized, got 6 weeks of IV antibiotics. His cancer was in remission at this point, but this is a previously irradiated area. And at this point, we're talking about getting a free flap in order to get that coverage. We came back, took the antibiotic spacer out. Again, the ViviGen was placed in the tibio-talar and subtalar joints. A rectus free flap was placed over this for a good blood supply. Now he had completely healed with the free flap that also, along with the fusion, as you can see, has a nice consolidated mass. He actually was a worker at JFK and actually went back to work for a bit of time, but unfortunately the prostate cancer recurred, and he recently passed away just before COVID. But one of the things his daughter told us, she's a hospitalist in the Philadelphia area, where he was so happy that for at least the last few months of his life, he was able to ambulate and have interactions with his family, which, as orthopedic surgeons, sometimes we feel like we're not real doctors, but at least we get to help these people in quality of life even towards the end. So this is something that we were really excited about, being able to get him back on his feet, especially as he spent time with his family. So 2 pretty hard cases. I picked another one, as I was getting more and more confidence in the product. This is a 79-year-old female, morbidly obese, history of lymphedema, outside surgeon after a trip and fall, fixed the left distal femur, who honestly, if this had been when locking plate technology first came out, this is amenable to what we were first doing when we didn't know any better. It was relatively well aligned. However, obviously now we wouldn't do a construct that's so short. We wouldn't lock all these screws up top, and certainly, even if it was intra-articular in this patient population, we wouldn't keep the patient non-weight bearing for 6 months. She showed up in my office at that time, still painful. And this is the CAT scan I received. You can see the large bony void, especially in the medial aspect of the metaphysis there. And I basically told the patient that 1 of 2 things are going to happen when we start walking on her. Either you're going to heal or she's going to break the plate. And interestingly enough, on a Sunday morning, I got a call saying that she couldn't walk, and this happened, not surprisingly. So we brought her to the operating room. This is a technique that Frank Liparachi taught me, and something that we continue to get better at, where our construct is going to be a long nail and a plate technique. And then for us, because our previous workup had been negative for infection, wanted to go ahead and pack this large defect, which is about probably 7 to 11 centimeters, with ViviGen and bone marrow aspirate. This is the construct we chose. That's a 9mm nail with probably an 18-hole plate, which is custom contoured to the patient's anatomy. This is a construct that is linked at the level of the distal femur and allowed to weight bear automatically right away. We did take cultures at the time as well, just because I'm paranoid, and that was also negative. This is her out at about 6 weeks or so, and you can even see that the consolidation is happening. And she recently came back for her actually 2-year follow-up X-rays. She started walking without a cane at 5 months. This is her at about 5-6 months follow-up, and then this is her at 2 years, which is full consolidation of the fracture site without any pain. She actually comes back for now yearly injections for knee osteoarthritis, which I really don't want to replace at any point due to that complication rate. But this is something where I was going back and forth about doing a distal femoral replacement, and I'm glad I didn't. 1, because I'm pretty sure that would have gotten infected. And honestly, with her native anatomy, I don't think it would have gotten as a good as a result as we got here. So after these three cases, I started to believe a little bit more, you could say, and started kind of expanding my profile. But before we go into those cases, why don't we take a few questions? Pyle, do we have anything in the chat that we can talk about?
Yes, Dr. Yoon, we did have a question come in from the audience. What is the largest defect you have filled using ViviGen?
That lady you just saw right there is probably the largest defect, which probably was around 7 to 11 centimeters, depending on which side of the femur you measured. I recently did a 4 centimeter defect in an infected femoral non-union. But that's really the largest one I've filled with ViviGen.
Great, thanks. So we can proceed and then address additional questions at the end.
Sure. So I started obviously expanding my portfolio and using this where I would normally use Crest. This is a 62-year-old female, 12 weeks out after getting her female ankle fracture fixed at an outside institution. Obviously, the construct is sound. However, maybe due to her osteoporosis, maybe we would have added a syndesmotic screw, but obviously this went on to non-union failure, both on the lateral and medial side. I took that down, went with a longer plate. That entire gap in the fibula is filled with ViviGen, as well as the medial aspect of the shoulder, the medial mal, which was cored out back to bleeding bone. We made her weight bearing tolerated about 6 weeks after this procedure. And here you can see at 6 weeks, she's walking with a cane, but she has no cane back to her ADLs. Consolidation can be seen even at 6 weeks. This is her at 3 weeks, and she complains more about her pes plano valgus than she does about the ankle fracture non-union. And recently we saw her back, and this is her kind of 1 year follow-up where it's the non-union sites have fully consolidated in. And she's mad at me because I won't do a calcaneal osteotomy to fix her pes plano valgus because her pain went away with an insert, but I'm just glad we got her bone to heal. Upper extremity, certainly not out of the realm of indications here. There's a 70-year-old retired female who still works and active. Appropriately, she had a nightstick, treated non-op, but she had continued soreness and pain, even with the little things, opening doorknobs, carrying groceries, despite wearing a brace. CAT scan showed an ulnar non-union here. When I do these non-unions, I typically I leave as much bleeding bone as possible, and that's why you see that kind of the callus that was there. I kind of leave that if it's bleeding, just because I feel like it closes the gap more. And I contour the plate to that anatomy, not necessarily the other way around. I dual plated this with mini frag fixation, added ViviGen, pressed across that site. And she came back at 2 weeks, and she said the soreness is already gone. Whether that was from the plate fixation or from early healing, that's obviously in the ViviGen animal data. Who knows? It's hard to know clinically, but at week 6 she went back to work without a brace. This is her healed, and actually she recently came back at 1.5 years because she fell on her forearm and just wanted to make sure everything was okay. And I apologize, I don't have the X-rays with me, but there was nothing wrong with the consolidation. She's pain-free. Here I want to take a moment to go over a case, I would say like the cousin of ViviGen. This is PliaFX Prime, which is a little bit different than ViviGen because it doesn't have the osteogenic osteocytes. However, this is the only DBM on the market that's 100% DBM and moldable fibers. So if you guys have used other products on the field, there's carriers that make it kind of mushy, and as soon as you squish it in, it kind of almost dissolves on the way. This is something that is almost equivalent to, I'd probably say almost like a marshmallow, which I add some bone with it and improves the handling. And oftentimes this is something that I'll add with either RIA aspirate or with ViviGen now in order for larger defects to get kind of the bone graft to stay kind of where it is. An example here where there's a 30-year-old male with this intra-articular distal radius fracture with a carpus that's subluxing dorsally. Here, you have to think about it as like a tibial plateau, as on the CAT scan. When you reduce this fracture, you're going to have a bony void underneath. Oftentimes, using chips alone is kind of difficult to do. It takes a lot of time to prepare it, and by the time you rondured it all up, it's kind of like a powder. And if you've used DVM before, this is where this kind of just melts into a place, and you hope it doesn't go into a joint. And here, the size of the defect is relatively a little bit smaller, so you might not want to use ViviGen. And PliaFX Prime is actually an ideal kind of product for this. Here, I went dorsal. I put the X-Fix on first for the reduction, got the length out right, did a dorsal approach, opened the book, elevated and tamped up the joint line, backfilled it with PliaFX Prime, closed the book there. I put the wires in on the floral using it as a guide for my screws. Plated both the radial and intermediate column. Here you can see the floral there. I leave the X-Fix on for about 4 weeks just to protect, not necessarily even the cartilage, but the dorsal capsular ligaments that are damaged with the injury, but also a little more unstable with your approach. I take them off for 4 weeks, get them back to moving right away. And this gentleman actually, much to workers' comp's happiness, went back to work at 3 months. And these are his latest X-rays we have here. And when we're talking about ViviGen and its applications, what I started to see was early consolidation, earlier symptom abatement, and for the first time, something that really correlated with the basic science studies that we saw from Elena and the PhD groups down in LifeNet. And I started to think where else I could use ViviGen. Intra-articular fracture, especially in the elderly, we always want to get everyone up and walking. This is an 82-year-old male with a lateral condyle fracture, which is intra-articular. Here, I placed the ViviGen within that fracture site before compressing across with a 6.5 cannulated screw. This is someone who's a very motivated individual. I made him foot flat weight bearing with the heel slide almost immediately and advanced him at 6 weeks. This is him walking at week 7 without a cane. And then at week 12, this is him going up and down stairs. And I kept waiting for him to fall because he sent me this video on his cell phone. And I was actually, extremely terrified about what would happen next. But he actually gets down without any issue. Thank God, because I didn't want to see him in the ER after he'd fallen off this. Holding the railing was actually made me feel a lot better watching this video. A harder fracture here is an 85-year-old female fall downstairs. You can see the gravity of this situation where the skin was actually puckered in that proximal fragment in between the patella. This is a perfect indication for nail plate, and you see where that kind of the haziness and lucency you see, that's where that bony void was. A lot of these osteoporotic folks, this is not uncommon. When you flip that cortical window out, you see huge cancellous void, especially in the metaphysis. That's where I'd use a medium ViviGen there in an acute setting to kind of get that packed up. Nail plate combo, foot flat, and advanced weight bearing is tolerated. Now I make these patients weight bearing is tolerated right away after these results. And she actually came back. This is her 1-year follow-up visits. You can see full consolidation of the medial column, even posteriorly. She had robust consolidation of the fracture site there, doing very well. Plateaus, started using it in lieu of cancellous chips, hoping that we can get these patients healed faster a little bit. 82-year-old female with this depressed fracture, elevated the joint line, used a rim plate here to get additional articular surface support before closing the book and putting a plateau plate on. And she actually went on to heal after being foot flat weight bearing, made a weight bearing is tolerated 6 weeks. And this is where you don't see the articular surface compressed down. And I started thinking about younger folks. This is a 31-year-old male who typically in this fracture pattern, I would not let weight bearing for about 12 weeks. This is his construct after elevation and backfilling with ViviGen. And this is him at 6 weeks. And his wife told me that about 2 weeks prior to this visit that he had already started weight bearing. And I was kind of waiting for a collapsed joint to be seen, but I didn't see it. He had no pain. He had a full range of motion. And that was actually the last follow-up. He wouldn't come back because he was too busy with work. And in my practice, we keep thinking more and more about how I can use ViviGen repeatedly, as well as in the non-union scenario. It's a no-brainer. Even in a previously infected setting, as long as you can prove that the infection is cleared, it's been an important part of my practice. For acute fractures, yes, for bony voids, especially in the osteoporotic population, distal radius, plateau, and pilon. Research needed. We currently are running a multi-center study looking at non-unions and acute fractures, but even looking at the plateau cohort. We're looking at cohort comparison, looking at early weight bearing at 6 weeks with people who got ViviGen and our classic treatment, which is typically cancellous chips, to see not only what the radiographic outcomes look like, but what our functional outcomes as well as the cost looks like getting back to work sooner. Hoping to have that data analyzed by the end of November, hopefully. And because what we're seeing now with these allogeneic cellular allograft and ViviGen is hopefully faster consolidation and better outcomes and getting our patients back to work and back to their function sooner, especially in osteoporosis. So with that, I really thank you guys for your attention, and I'll take any questions that anyone may have.
Thanks, Dr. Yoon. So we did have a few more questions come in from the audience. First, can you comment on the cost effectiveness of ViviGen versus alternatives?
So I think that that's a very important question because the cost of ViviGen is, it's not cheap, let's put it that way. However, the way you have to look at non-union surgery in general, or even a fracture that is not healed, one return back to the OR certainly could cancel out, if not still provide cost savings if using ViviGen to get more reliable healing. Obviously, we need more data in this arena, which is why we're conducting not only the multi-center study, but looking at even my previous uses of ViviGen to make sure that this is actually true. But anecdotally looking at it, looking at patients who may have a high risk of non-union, and those patients are obviously those with bony voids, acute fractures with malnutrition and or diabetics or smokers and things like that, where you would have trouble healing. This is an area where getting it right the first time and avoiding the second surgery, I think, may have a more important cost-effective effect on the healthcare strain more than you think. That's why we're working really diligently to get more and more data out there, as the cost is relatively high, but one, it is cheaper than infuse, which is considerably cost prohibitive. And as we get more data out there, hopefully we can convince more MEOCs to get it into their hospitals.
Thanks, Dr. Yoon. And you touched on this, but can you comment on the differences in outcomes you're seeing when using ViviGen versus what you were seeing with Allograft?
The main thing is the lack of complaints from the donor site. And over the years, I've tried everything for the donor site in terms of graft. I've even used, liposomal bupivacaine in that area to help with pain control. Those patients with the pannus, not too uncommonly, I'm putting them on antibiotics to help that wound heal from the graft. That's like the main thing that I'm the happiest about. And the second are some of the defects that are almost borderline. Obviously, for the larger defects, you know that you're going to run out with Crest in terms of getting that option, in terms of volume. But for the larger defects, having ViviGen around certainly has helped solve that. And also, it's something we have a lack of data on, but a lot of these patients with non-unions are getting older and older, and we have to do more research and look at the viability of the cells that you're getting from the older population. I don't necessarily know if, grandma who's 85 with a humeral shaft non-union, I don't know if her Crest is going to be any better than cellular allograft with something like ViviGen, because we haven't really looked at the potency of Crest in that regard either. So, just to briefly summarize, the main things I've seen is from donor site off the bat. But two, when it comes to volume and running out, the ViviGen has kind of alleviated that issue and worrying about if you're going to have enough.
Great, thanks. And so we talked about ViviGen and PliaFX Prime in this talk. How do you decide whether to use ViviGen versus PliaFX Prime?
So it's almost like it's an interesting question because there's more often than not, I may or may not choose to use both. So to be 100% honest, for you guys, I always tell you, you guys need a size in between your small and the medium, like a medium. And sometimes, the void, because I use a lot of this in acute osteoporotic distal radius fractures that need to be fixed. Most of my geriatric risk fractures I'm non-oping, but those that need to be fixed, that metastasis is, has a paucity of bone there. And it's kind of the perfect area to mix PliaFX Prime and ViviGen because it helps it stay, but also gives it that kind of extra punch to get earlier healing. For young patients who have that issue, like in the wrist and upper extremity, I'm using PliaFX Prime in the upper extremity more and more because it's more moldable and I'm getting there. But if a patient's more high risk, like osteoporotic, a smoker, or someone I'm worried about healing off the bat, that's where I'll lean towards either mixing in or using ViviGen alone in acute fracture.
Great. Another question from the audience. Have you had any failures with ViviGen? And if so, why do you think it failed?
I have had two, and I think that one of them, they're both hindfoot fusions. And they were both history of previous infections. And one person didn't get to me until he was 9 months out after a hindfoot was infected, and he was uncontrolled diabetic. So I had actually spacered him twice, got his diabetes under control. And when I did the hindfoot nail, actually that started to loosen. So I converted him over to a spatial frame. That also had residual, I guess, a fungal growth. So I had to re-debride him. But for him, after the spatial frame was off, luckily he had enough consolidation where we left him off and achieved him in a total contact cast. And he's actually consolidating. The last person, someone similar, however, he's an end-stage renal patient with uncontrolled diabetes that got reinfected after spacering him twice after an open trimal he sustained. And he currently has something similar where he's in a total contact cast and just weight bearing through that with no hardware inside, being treated with antibiotics. So those are, knock on wood, the only two failures using ViviGen I've had so far. And as you can see, those scenarios were kind of like disaster scenarios where infection was lingering for a long time in poor hosts. So I think that kind of is an exception to the rule, and I don't think necessarily using Iliac Crest in those situations would have really gotten them to heal either.
Thank you, Dr. Yoon. And we actually have a question for our PhD, Dr. Janulis. How do we have viable cells in ViviGen without an immune response?
Thanks, Pyle. Yeah, that's a good question, and we get that quite a bit. So ViviGen is focused on lineage-committed bone cells. And so as a cellular bone allograft, the first thing we do to ensure safety and the elimination of a potentially immunogenic response is to first thoroughly clean the graft and remove all bone marrow content, which is the major source of components that would elicit an immune reaction. But then we also further evaluated the cells that are within ViviGen, the lineage-committed bone cells, and we did an internal immunogenic assay to test the immunogenicity of those cells. And we found that in this in vitro assay, they actually did not elicit an immune reaction as compared to the positive control. And when we looked further, we actually found that these bone cells, these lineage-committed bone cells that are within ViviGen, do not actually express the cell surface antigen, the major histocompatibility complex protein, which is the most likely culprit to trigger an immune reaction in the patient. So this tells us that bone cells, osteoblasts, are inherently non-immunogenic, which in turn makes ViviGen, which contains these cells, a non-immunogenic bone graft.
Thanks, Elena, and thanks, Dr. Yoon, and thanks today to our attendees. That concludes our webinar on ViviGen and PliaFX Prime. We hope you found this time beneficial, and if you have any further logistical questions, please feel free to contact your local LifeNet Health bioimplant specialist. And if you have further technical questions, we will be available in our virtual booth throughout the week at the OTA meeting. Thank you very much, and we hope you enjoy the rest of your day.
Thank you, everybody.